Okay, so we will get started with today's webinar on laser therapy for wrist and hand conditions. I really do appreciate everyone taking the time out of their day to listen in. This particular subject was a lot more daunting than I thought, because when you look at the number of conditions that you guys would be treating on a day-to-day basis in this area, I could probably have done 2 or 3 webinars, so I have a lot to cram in into one short webinar. Remember that this webinar is recorded. You can listen at another time. You'll receive an email with a link to it probably within a week or so. If you have any questions as we go along, please write them in, and I'll get to those questions at the very end of the webinar. So it's best to write them as you think of them, and then I can address them at the end of the webinar. Okay, so let's get started. I'm going to do a basic anatomy review very quickly, just so we can refresh our memories with respect to the anatomical regions of the wrist and hand. And then I'll get into not all, but some of the more common conditions, their etiology and pathogenesis briefly, as well as some of the research with low-level laser therapy or photobiomodulation and these conditions. And then I'll talk a bit about, obviously, how we use BioFlex laser therapy to treat these conditions. Many of you out there have our equipment. Some of you do not, obviously, and some maybe are interested or what have you. So we'll talk a bit about that as well. And then at the very end, we'll have some time for some questions and answers to finish off. So quickly looking at the articular and bony structures of the hand, we of course know there's 2 rows of carpal bones, and of course the metacarpals and phalanges articulating proximally at the wrist with the radius and the ulna. With respect to musculature, if you're looking at the flexors and the layers of the flexors that come down in the forearm into the wrist, we all of course are familiar with the different flexors, as well as the intrinsic muscles of the hand. So those are important when you're looking at conditions like carpal tunnel syndrome or stenosing tenosynovitis or other muscular tendinous conditions that cross at the wrist or into the hand as well. With respect to the extensors, similarly, you have a deep and superficial layers of extensor muscles. It's interesting to note that when you have a higher prevalence of conditions at the elbow, you oftentimes will see some conditions at the wrist and the hand as well. So it's not uncommon that you're treating the elbow and the wrist and the hand at the same time. The carpal tunnel anatomy, which is familiar to all of us with treating carpal tunnel syndrome, and looking at the median nerve just deep to the carpal tunnel ligament. And of course, this space is really crammed with tendons as well, so there's not a lot of area for that nerve to freely pass. And of course, that's the problem in carpal tunnel syndrome, is when you get swelling and inflammation in the tunnel, it will start to cause compression and then symptoms related to median nerve compression. Okay, so let's look at some of these. Again, it's not an exhaustive list. I've just tried to choose some of the more common ones that we come across in clinical practice. Of course, the first one being carpal tunnel syndrome. It's a fairly common condition. Oftentimes, it's not quite known the specific cause or idiopathic. It can be bilateral. It's not uncommon to be bilateral, actually. You'll see hypertrophy of the synovial membrane of the flexor tendons. This can be caused by degeneration. There might be vascular sclerosing. Obviously, there'll be some swelling. And this all can lead to collagen disruption as well. We're, of course, familiar with the old computer overuse scenario, that in and around 15 hours of use, you start to get, under that, there's no increased prevalence, but as soon as you get over that per week, then you start to see a link between carpal tunnel syndrome and overuse on the computer. Other reasons for carpal tunnel, everything from unusual anatomy or aberrant anatomy, whether it's a congenitally small carpal tunnel or cysts or lipomas. We know that if fractures secondary may be causing carpal tunnel syndrome. There could even be infectious issues causing swelling and inflammation. Inflammatory conditions like RA or tenosynovitis or gout that take up volume or space in that tunnel may also lead to carpal tunnel syndrome. In fact, with RA, you do tend to see it fairly frequently. There can be increased canal volume with respect to edema, and that's oftentimes the case with pregnancy. So you will see temporary carpal tunnel syndrome due to pregnancy. Of course, obesity, hypertension, generalized edema can also cause an increase in prevalence of carpal tunnel syndrome. It is more common in certain metabolic conditions, including diabetes and hypothyroidism as well. Some of the symptoms I'm sure we're all familiar with, whether it's a sensory disturbance in the median nerve distribution, with long-term compression of the nerve, you start to see weakness and thenar atrophy. So these are all symptoms that you're looking at to gauge the severity of the carpal tunnel syndrome. There's actually quite a few good clinical research trials out there with reference to low-level laser therapy or photobiomodulation and carpal tunnel syndrome. This particular one I pulled up was a double-blinded RCT. I looked at about 79 patients. They are diagnosed with mild to moderate carpal tunnel syndrome. I do have to tell you all that generally speaking, you'll see much better results in the mild to moderate cases. As soon as you get into the severe cases, the prognosis, even with laser therapy, is pretty poor. So keep that in mind when you're treating these conditions with respect to what you're trying to achieve. It's a lot more challenging. In this particular case, they used just a laser probe at 780 nanometers, that's near infrared, continuous wave at 30 milliwatts. They looked at they treated 4 points and 90 seconds per point. You can see initially they treated 5 times a week, then once per day for 2 weeks. So a total of 10 sessions, and every other day for 3 weeks, and then for a total of 20 treatments. So they were looking at visual analog scale pain. They were looking at the Tinel sign, whether it was positive or negative, and they also did median nerve conduction studies as well. This particular study found that there was a significant reduction in pain in the group that was treated with low-level laser therapy. They also found there was a reduction in the percentage of patients with a positive Tinel sign, which is that tapping of the median nerve over the carpal tunnel. And they also noticed a shortening of the sensory and motor latency in the neurometrics examination, which is indicative of healing of the nerve. So overall, this paper did show that it was favorable to treat carpal tunnel syndrome with laser therapy. This next paper was a systematic review. They looked at 7 randomized controlled trials. So remember, a systematic review is a lot more powerful than just one single randomized clinical trial. Overall, there were 270 wrists that were treated with laser, 261 in control groups over these 7 trials. And in this meta-analysis, it was revealed that laser therapy improved the hand grip. It improved or lowered the VAS for pain, and the SNAP, which is a testing for the objective functioning of the wrist after 3 months, as well as follow-up for, again, mild to moderate carpal tunnel syndrome. So again, just bear this in mind when you're diagnosing or you have a patient come in. If they're in this range, you'll see a much better response than if they're in the moderate to severe or severe category. All right, wrist sprains, very common. They're graded, as we all know, sprains are graded from 1 through 3. So either mild, which is just stretching, to moderate, which is some partially torn ligaments, perhaps some even loss of function depending on the severity, and then a grade 3, which is a complete severing of the ligament, oftentimes associated with fractures as well. So usually what we see is grade 1 or grade 2. Sometimes you see the severe ones, but typically the 1 and 2, and they'll have the best prognosis as well too. So obviously wrist sprains are most commonly occurring with a fall in the outstretched hand. This can be just from tripping over something or in elderly patients that have balance issues, that kind of thing. You can also see it in many sports. I have an interesting case study I'll talk about myself that happened during basketball that was quite interesting. So symptoms, obviously the pain, there's swelling and pain in and around the wrist. It tends to be fairly persistent, especially with wrist movement. Initially, there may be bruising or discoloration or hematoma. There may be a kind of crunching or popping noise inside that wrist as well, and some cardinal signs of inflammation as well. Wrist fractures. Now, you can treat and have good results treating fractures with laser therapy, but you have to get the light directly over the fracture area, and this may be prohibited if there's a permanent cast on. So if the cast is removable, like a splint or what have you, then you can much more easily get at the fracture site. We all know there's different types of fractures at the wrist, the Colles and Smiths and scaphoid, Barton's, Chauffeurs, and green stick fractures. I'll leave it up to you to research those if you're not familiar with them. The one case that I should mention myself, actually, playing basketball, I landed on an outstretched hand going up for, I'm sure it was a pretty amazing dunk, but and so when I landed on my wrist. Pretty sure it was a bad sprain, and months went by, and it's still painful. A year went by, still bothering me, but I just ignored it. Turns out it was a fracture. Indeed, a fracture of the scaphoid oftentimes presents as a bad sprain. So bear that in mind. If anyone's had a bad fall or a fall and you suspect a wrist sprain, I would get an x-ray just to rule out a fracture at the neck. Because if there is a fracture there and it's not caught early, like myself, you end up having a surgery, which I did, having a bone graft to replace the avascular zone where that artery tends to be severed and the bones don't heal properly. So I would always err on the side of caution when anyone has a sprain and the mechanism suggests on a fallen outstretched hand is to rule out a fracture as well. A few research articles on laser therapy and fractures at the wrist and hand. This particular one, we're using 830 nanometers, so very similar to what we use here at BioFlex. They were looking at closed bone fractures at the wrist or the hand. They looked at 50 patients. They had not received surgical treatment, so they weren't requiring surgery, and they were randomly assigned to two groups. So they had a laser group or they had a placebo group. Laser group had 60 milliwatts. Notice they used 10 hertz, which is very interesting. That's what we tend to use as well. And you can see the actual protocol here. They were looking at pain and function, disability, grip strength. They also did x-ray follow-ups, and both before and after treatment and at 2 weeks post-treatment. Now, if you look at the results, the first group is the laser group. So you're looking at a VAS starting at 6, a DASH score, which is a functional evaluation at 39. Remember that you want the DASH to be lower and to have a better outcome. You're looking at hand grip and finger grip strength. So in the laser group at the very beginning, before treatment, you can see what it was. And then after the treatment, the VAS went from a 6 down to a 3.8. The DASH went from about a 40 down to about a 20. The hand grip increased or doubled, as did the finger grip strength. If you look at the placebo group, starting at 6, went down to 5. So, a typical placebo reaction, but not as significant. The DASH went from a 40 to a 34. So again, not a overly significant improvement. Well, I mean, improvement, but not overly significant compared to laser. Hand grip and finger grip also showed very slight improvement. So it was obvious that laser therapy was helping. When they looked at the follow-up 2 weeks, you can see the VAS went down to a 1.3, whereas the placebo group went to 3.2, and then the DASH continued to lower to 11, whereas the placebo group was still significantly higher at about 28, and the grip strength, again, improving with the laser group and not so much for the placebo group. So the results overall, they showed that after treatment with laser therapy and the follow-up, The laser group exhibited significant changes in all the parameters compared with the baseline, and they concluded obviously that laser therapy can relieve pain and improve the healing process of closed bone fractures in the human wrist and hand. De Quervain's tenosynovitis. We see this fairly commonly, at least a few cases, maybe 1 or 2 cases a month, but it is a very common condition, and it's a tough condition to treat. You're going to have a long treatment plan for this one. It is a painful chronic inflammatory condition at the wrist, at the base of the thumb. Pain will increase with abduction of the thumb, like grasping, using a pencil or what have you, especially with ulnar deviation at the wrist. With a chronic condition, you'll start to see thickening and swelling in this area as well. So that anatomical snuff box. The prevalence is much higher in women. It's about twice as high in women compared to men. And again, a little bit more common once you get into your 40s and 50s as well. I mentioned this earlier that some conditions, including this one, has a higher prevalence and is more common when you have issues going on at the elbow, in this case with epicondylitis. In industrial settings like factories, that kind of thing, you'll start to see a much higher prevalence when the patient has wrist pain and a positive Finkelstein. So it's actually a fairly common kind of scenario in workers that work in that kind of repetitive factory setting. So there is radial-sided wrist pain. It can radiate up into the forearm, especially with the grasping or extending the thumb. The pain is usually described as a constant aching or burning or pulling sensation, usually again aggravated with repetitive lifting or gripping or twisting. So these patients usually need to take time off work. Otherwise, it becomes a real chronic, long-standing problem. So there is swelling in this anatomical snuff box. If you palpate, there's tenderness in that area. You'll see decreased carpal metacarpal and abduction and range of motion at the first digit. There might be even palpable thickening of the extensor sheaths. An ultrasound is very helpful as well for diagnosing this condition. Arthritis. Well, there's many different types of arthritis. Obviously, I'm going to focus today on osteoarthritis and rheumatoid arthritis in the wrist and hand. But of course, other conditions like gouty arthritis or psoriatic can also affect this region. If you look at osteoarthritis, it's not just to say there's simple cartilage loss. There's many things going on. So it's a multi-tissue problem, everything from the bone itself to the joint lining, which can have synovitis and edema, interarticular edema. So all these things are going on, not just the actual cartilage loss. In Canada, now I know people are listening from all over the place, but in Canada particularly, osteoarthritis, especially of the hand and the wrist, is a fairly common condition that causes a lot of loss with respect to in the workplace. And you can see the numbers from 10 billion up to in 2010 projected to be 340 billion loss by 2030. Roughly over 4 million, so over 10% of the population have osteoarthritis, and projecting that to be nearly 10 million in about 10 years. So we know it's a syndrome. There's joint pain, there's functional loss, reduced quality of life. This is a real problematic for people because it prevents them from doing their things they love to do, whether it's music or drawing or whatever it is. So these patients really are looking for some type of relief and help other than, standard medications, that kind of thing. So I already sort of talked a bit about the prevalence. Lots of good research. This particular paper looked at the effects of low-level laser therapy on Bouchard's and Heberdine's nodes in osteoarthritis. In this case, it was a randomized control trial, 34 patients. They were given anywhere between 5 and 10 sessions to upwards of 85 joints. This is including in all these patients. Typically, in this case, it was proximal and distal interphalangeal joints, and they treated twice a week. We do recommend 2 to 3 times a week for treatment plans. They were looking at the visual analog scale, pain, the perimeter or the ring size in millimeters, the range of motion. They were all looked at baseline and then after 5 treatments, and then after 7 sessions, and then after 8 weeks after the treatment. So the results were that they found that laser therapy significantly reduced pain, reduced the ring size, so that's good news if you're trying to get your ring to fit, and also increased range of motion after the 5 and 7 treatments, and the effects, they said, were actually quite significant. There was no further significant change between 7 and 10 treatments. However, the effects achieved after those sessions persisted for 8 weeks. So this is really the main thing here, is that when you're treating patients with osteoarthritis, you can expect long-standing improvement, but they will still require ongoing care. So I want you to see these patients maybe a month or 2 months after their initial treatment plan for some ongoing maintenance treatment. This will really help to keep the symptoms at bay. Rheumatoid arthritis affects a little bit different joints typically than osteoarthritis, oftentimes the knuckle joints or the MCP joints. It can also affect the proximal interphalangeal joints, and also occasionally at the wrist itself, the carpal metacarpal joint, midcarpal joint, and radiocarpal joint, and as well as the joints in between the carpal bones. RA has 5 steps. It includes initially white blood cell. Of course, it's an autoimmune issue, so the white blood cells invade. They start to cause inflammation. The synovial lining starts to become inflamed. This can lead to pannus formation, which is an additive synovial tissue lining that starts to increase at a very rapid pace, causing this sort of swelling or pannus tissue collection. This will eventually lead to cartilage and bone damage in the area as well as edema. So you have all these different steps going on in rheumatoid arthritis. So if you look at the big picture in the wrist and the hand, if you're trying to figure out what's going on, usually RA is affecting the proximal interphalangeal joint, definitely the MCPs, a little bit more rarer at the wrist, whereas OA tends to affect the distal interphalangeal joints, and to a lesser degree the proximal, and to a much lesser degree the MCPs. It does highly affect the CMC at the thumb joint, and that's because of the overuse scenario of that particular joint. This particular study, I usually shy away from animal model studies, but there were no good ones with RA at the wrist and the hand. So this particular one was on rats, so bear that in mind. But I found it interesting because they evaluated the histological effects of laser therapy for different stages. Now, it was at the knee, but the model itself was looking at rheumatoid arthritis. So they observed that laser therapy in both early and late progression significantly improved the white blood cell inflammatory cell count, the exudate protein, hemorrhaging, hyperemia, necrosis, distribution of fibrocartilage, all these things that you would associate with RA, they were all decreased, and quite significantly. So they concluded that laser therapy, at least in an animal model, is able to modulate the inflammatory response. So really in RA, you're looking at helping reduce the inflammation and slow the progression down. Because it's an autoimmune disorder, you're not going to significantly alter the actual disease process, but it can help in both early and late stages of rheumatoid arthritis. Another common condition at the wrist and hand is Dupuytren's contracture. They feel it's a hereditary condition that affects the fascia, and there's thickening under the palm and the fingers. There are different stages of it. Initially, there's nodules and pitting. Eventually, there's sort of rope-like cords that start to form, and then there's a deformation of the fingers towards the palm as the condition becomes chronic. Okay, so how are you going to treat these conditions? Well, let's look at the wrist. Everything from carpal tunnel to wrist sprain to fractures. The protocol is pretty similar. Our wrist protocol, uses a little bit longer time frames, and that's because The wrist is a very bony, obviously, joint. Lots of bone to get through, lots of tendons to get through, ligaments. So the time frame is a little bit longer. Looking at 8 minutes for red, continuous wave. And then for infrared, again at 10 minutes, so a little bit longer. Notice the frequency, 10 hertz. Notice that the paper I talked about earlier also used 10 hertz. 40% duty cycle, so a fairly low initial stage 1 protocol that we use. And a total of 18 minutes over that wrist is usually what we try to do. Location of, for the laser probe, we usually set it at 40%. That's about 75 milliwatts. The time will vary. We usually use about 6 minutes in total. Now remember, we're holding that laser probe, depending on what we're treating, anywhere from a few seconds on an interphalangeal joint to 10 to 15 seconds over the carpal tunnel. So placements. In carpal tunnel, we tend to wrap the array around the entire carpal tunnel. So on the palmar aspect, wrap the array over the carpal tunnel, and then we'll do another positioning that's parallel to the fingers that overlies the actual palm of the hand, overlying the sensory nerves into the thumb. You can even shift the array slightly distal to cover the affected fingers as well. I didn't really do a good job of showing you that. In the case of a wrist sprain, I prefer that you do 2 placements. You would wrap it around the wrist on the palmar aspect and then wrap it around the wrist on the dorsal or volar aspect as well. So 2 placements there. Remember, when using the laser probe, make sure it's held perpendicular 90 degrees. Otherwise, you'll lose some of that energy if it's at an angle. And remember to push down and depress the tissue. This allows for deeper penetration and better absorption of the light into the tissue. For laser probes and carpal tunnel syndrome, you want to follow the median nerve proximal to the carpal tunnel and then into the carpal tunnel, and then the sensory branches into the thumb, thenar eminence, and into the fourth and into the all the way into the fingers of affected as well. You're going to hold the probe over the carpal tunnel syndrome for the carpal tunnel for 10 to 15 seconds. You're going to hold it over the thenar eminence for about 10 seconds, and then as you start to get into the more superficial tissue, hold it for 5 seconds, 6 seconds, and then a little bit less as you get into the fingers itself. So again, holding that probe is important to understand. You're going to vary it anywhere from a few seconds all the way up to 5, 8, 10 seconds per point, even 15 seconds if you're not getting the result that you desire. So follow the pathway of the nerves, especially as it gets into the hand itself. If you have a LDR 100 probe, which is a red laser probe, I'd also recommend using it. That's more for pain control. It's not going to go really deep through the carpal tunnel. Severe cases, as I mentioned earlier, have quite a poor prognosis. So I'd be a little hesitant to take those patients on. It's mild to moderate conditions that seem to respond the best. If the patient's not responding after increasing the parameters, I'd suggest you treat the cervical spine at stage 1 on the affected side. And usually you're going to emphasize treating the C5 to T1 nerve roots, on the right or left side or bilaterally if that's the case. In carpal tunnel syndrome, I usually ask you guys to treat at least 3 or 4 days in a row if possible, and then go into treating 2 to 3 times a week until they start to make some good improvement. And then you can eventually make it down to once a week. The typical treatment plan for mild cases is about 10 to 15, probably upwards of 20. For moderate cases, you're looking at 15 to 30 cases, treatments in total. And severe carpal tunnel syndrome, again, very challenging to take that on because of the, oftentimes, they do release surgeries or what have you. Remember to address potentially underlying causes, whether it's ergonomics or systemic diseases, that kind of thing. For wrist sprains, you're going to use the same protocol. For the laser probe, you want to focus both on the palmar aspect of the wrist, for the laser probe. I didn't show it here, but you also want to treat the dorsal aspect of the wrist as well. So for carpal tunnel syndrome, just the palmar aspect. For wrist sprain, treat both the palmar and the dorsal aspect of the wrist and all the way around the circumference of the wrist. For de Quervain's stenosing tendinosynovitis, here you want to treat definitely at the source of the problem and a little proximal as well. So wrap the array over that anatomical snuff box, and I would also do a second position and wrap the array using the straps provided, just proximal to the anatomical snuff box where the tendons lie, to ensure that they're also getting proper treatment. For the laser probe, you want to follow the tendons of the abductor and extensor pollicis longus as it goes into the anatomical snuff box, and both proximal and distal to that area. For tendons, you want to hold for 5 to 10 seconds in around there. Don't hold it for 1 or 2 seconds. You need enough light to actually penetrate through the skin into the tendon sheath itself. And sometimes even the tendon itself is affected, so you want to have enough light that will penetrate definitely deep into the tendon. Arthritis. For the placement of the array, now I'm talking about arthritis of the hand now. We tend to, usually it's bilateral, so we'll tend to have the hands placed side by side, and we will treat both the palmar aspect using 2 arrays like so, and then flip the hands over and then do the dorsal aspect. Now again, the number of arrays will depend on the affected areas. If you feel you can treat all the affected interphalangeal joints or MCP or whatever that's affected with 1 array, that's fine. But you may need to use 2 depending on the size of the hand that you're treating. The protocol for arthritis is a little bit different than the wrist because it is smaller, less tissue, less bone. The time frame is a little bit less. You can see it's 7 minutes instead of 8 minutes using continuous wave. You can see that the 7 minutes instead of 10 minutes at the wrist for the infrared. And also note the frequency is a little bit higher stimulation, as is the duty cycle compared to the wrist. So overall, we tend to be a little bit more stimulatory in the hand as opposed to the wrist in stage 1. The probe, we also start off with 40% power. Laser probe, most commonly you're going to treat the first metacarpal phalangeal joint. I want you to hold it for at least 5 seconds, maybe 6, 7, 8 seconds right on that MCP joint. Go all the way around the perimeter, the circumference of that joint, and then you're also going to treat the affected interphalangeal joints, whether it's a distal or proximal. You want to treat again around the complete circumference of the joint, holding it for maybe 2, 3, 4 seconds before you move it to the next point. Treat all the joints and then go back and treat them again. That's perfectly fine. I just don't want you holding it for too long on one point, because then you might overstimulate them and the results won't be there. A few treatment tips. You don't need to be overly aggressive with osteoarthritis. Again, it's a degenerative chronic condition. You don't need to treat 4 or 5 days in a row. You can start 2 or 3 times a week. Move to higher increased dosaging and frequency a little bit more quickly if need be. OI joints do not do well with long periods of immobility, so make sure they're doing exercises. You can use heat pack to increase circulation. And I would also recommend, if you don't have a red probe, maybe thinking about adding that to your repertoire, because a red is really effective for small joints. You'll find a big difference if you include a red laser probe and infrared with respect to pain and inflammation. Don't forget to instruct your patient to do specific exercises, and those are important to do synergistically with laser therapy. For Dupuytren's contracture, usually one placement over the overlying palmar aspect of the hand using stage 1 hand protocol is adequate. And then you want to hold the laser probe over the nodules or the affected tendon. holding for at least 5 to 10 seconds per point. And you can go back and treat at least 2 or 3 times these particular areas. Dupuytren's contracture, you're not going to reverse it because it's probably hereditary, but you should be able to slow it down and improve mobility to some degree. Of course, the late stages of Dupuytren's is a little bit more challenging to have a bigger impact than the early stages of Dupuytren's. Okay, I know I've gone over time. I do want to invite everyone, if you haven't been received a certification, we're doing a training next Friday. It's 9 a.m. Toronto time until about 4:30 p.m. Toronto time, so it's a full day event. It's only $109, which is not too bad. There are CE credits for most of you that require those. So I encourage you, if you haven't yet signed up, go to our website and you can register online. It's fairly easy to do. If you have any questions or concerns, you can email me. My email is david@bioflexlaser.com. So I really do appreciate everyone taking their time today to listen in. And what I'm going to do is just to see if you have any questions for me. Kathy, I know you asked the questions about Dupuytren's and carpal metacarpal osteoarthritis. Kathy, if you don't mind just emailing me, it's a little bit more involved with respect to my answer there. I do have a question here. Is there a chart on dosaging for certain injuries, fracture versus De Quervain's? You know, with respect to dosaging, we tend to use the standardized protocols, whether it's a wrist fracture or De Quervain's, you know, that kind of thing. Where the dosaging is different is the laser probe and how long you hold it for, and I've made that clear. The deeper, the thicker the structures, the longer, the greater the dosage that you require. There's a range of dosaging, so I can't really specifically pinpoint to say one dosage is going to do the trick because, of course, everyone has different sizes of hands and wrists. Do I have any data on treating fibromyalgia? Yeah, fibromyalgia, I don't have any specific data on that. Generally speaking, we get fairly good results with fibro treating around the head and the neck areas, Catherine. But again, you may want to email me. I can see what I can find and I can try and get that out to you. Jill, okay, wow, you have a really long question there. So guys, it's hard for me to get all these answers in. I hate to do this to you, Jill, but do you just mind emailing me? Because there's a lot, I got to read through all that and sort that out. So I know you spent some time writing that down, but just email me and I'll see if I can get more of a concise answer for you. Would you treat psoriatic arthritis on the wrist as the same as RA? Yes, I would treat psoriatic arthritis similar to RA. Would laser therapy benefit diabetic with hand pain and numbness? Definitely. Laser therapy is really beneficial for diabetic neuropathy, which is what you're describing, Carolyn. So that would be helpful. So scleroderma has come up as well. I didn't put that in the big picture today, but we have treated scleroderma. We've actually even presented at a conference. So there is potential that laser therapy may be beneficial for scleroderma as well. What are all the pros and cons at home versus in-office treatment? Really, Allison, the major benefit from in-clinic is that you'll get the class 3B laser treatment using the laser probe. But to counteract that, if you're at home, you can treat more often. So I've seen great results both at home and in clinic, but my preference would always to be going into clinic to ensure that you're getting the correct treatment. And then depending on the scenario and the chronicity, that kind of thing, at home can supplement that, or if you go away or what have you as well. Any contraindications regarding Ehlers-Danlos syndrome? No, we've treated that before, and I don't see any contraindications for that. Thanks everyone for joining me. My next webinar is in a couple of weeks, and I have training next Friday. I hope to see you then. Have a great day. Thank you.